All right, good evening, everyone, and thank you for joining tonight's Woo You event with Dr. Justin Schweitzer. We are going to talk about attacking ocular allergies, current and future trends. So in our Stop the Itch series, our other doctors did a great job of teeing up this presentation, and we'll get to focus a little bit on a review of what we've discussed about before, and then more so some of the treatments that we have that are new and upcoming as well. So I'm your host, Dr. Ariel Sorenzi. So I'd like to introduce our speaker for tonight. He is a Woo U alum. we were just talking about this is his third event, so we just can't get enough of him here. So he was born and raised in Jamestown, North Dakota, and attended Jamestown College and graduated with degrees in biology and business administration in 2002. He attended PCO and graduated summa cum laude in 2006. After graduation, him and his wife moved to Sioux Falls, where Dr. Schweitzer enjoyed a great general practice. And in July of 2013, he completed his fellowship training in advanced anterior segment surgery care and pathology at Vance Thompson Vision. He's a member of the American Optometric Association, American Academy of Optometry, the Scleral Lens Education Society, and the South Dakota Optometric Association, and has had multiple articles published in scientific journals. So thank you so much for joining us tonight, Dr. Schweitzer, and we really look forward to your talk.
Hey, thanks so much, Ariel. Yes, an alum and enjoy it every single time. It's always a great group to lecture with and for, and it's an honor to have the opportunity to do it. So everyone, thanks so much for all of you for taking time tonight to be here with me. I say this often because it's the truth. It's never easy at the end of a long day to get out of clinic and spend another hour, trying to learn about something new or reinforce what you already know and learn about new things, and whether it be, anterior segment disease, glaucoma, allergies tonight. So just really appreciate everyone's time and commitment to being here. And, I'd love doing these things because I think it helps to move our profession forward. I think we learn together when we do these things, whether it's virtual or live. And this is just another opportunity to spend a little time together, even though I'm not in a live setting with you all. At least I can stare into the camera and know there's plenty of you there listening and hopefully learning and enjoying this with me as much as I am. In regards to financial disclosures, none really are going to come into play in this particular lecture, but these are it, as I kind of have to show those when we're doing anything that is cope oriented. So, allergy season ahead, here in South Dakota, it's already started. We are full-fledged in spring here. We get 4 seasons here in South Dakota. Winter is probably the worst, not from an allergy standpoint, but a standpoint of just living here. Gets cold, and allergy season usually is calmed down at that point in time, unless it's more of a perennial allergy type of situation. But right now in the spring here in South Dakota, we're running into it, and we're seeing more and more of these types of patients in our practice coming in our doors and having to manage them. And what I'm going to do tonight is we're going to do a little review of the different types of allergic situations. We're going to talk a little bit about the biology around it. I'm not going to spend a lot of time because I know that has already been covered earlier. My main focus tonight is just a few tips and tricks on managing your patients that come in with allergies, and then going through some treatment options that are out there. And some of those treatment options are going to be review. Some of those treatment options are going to be new. Some of these treatment options are going to be the future. So there's going to be a variety of different things that you're going to get from me tonight. And at some point, you might say, boy, I already know this. Great. That's what I want. And at some point I'll say, boy, that's reinforcing what I already know. And at some point you'll say, boy, I could take that back tomorrow and maybe manage some of my patients that have some type of allergy and make your clinical practice in the allergy world a bit better. So I really wanted to start off with this because it is so often that there's this overlap between dry eye, allergy, and blepharitis. It's pretty rare that you have patients that come in that just have an allergic conjunctivitis, or just have dry eye, or just have blepharitis. Most often these things are overlapping. And I think that's really important tonight to remember, because as we're talking about allergies and we're talking about treating allergies, often you're not only going to be just using one allergy medication. You're going to be thinking about, boy, this patient also has dry eye and I have to manage that. This patient has some type of blepharitis or MGD and I have to manage that. The combination of all these things, you're going to have patients on multiple medications. Although tonight we're focusing on allergy, just keep in mind there's a big overlap between these. When we think about point of care testing in dry eye, I think in optometry, we really embrace this. A lot of us have systems in our practice like tear osmolarity, MMP9, we're doing mybography. So we've really embraced those point of care tests. Tonight, we're going to touch a little bit about some point of care testing in allergy. And I don't know if we've really latched onto that yet, that we've really embraced it as a profession. I think we've had to a degree. And, it was interesting talking to Ariel before we jumped on here. She has allergy testing or point of care testing in her practice. So it was great to hear that. We have that in our practice. And hopefully, as you see some of these different technologies, and I get into a little bit about, some of the point of care testing, you'll want to implement that in your practice. I think the other thing that's interesting is dry eye. I mentioned this when I give a dry lecture. I say it's not hard to manage dry or at least identify it. You really need 4 things. You need vital dyes and staining. You need a questionnaire, which is very, very important. You need a slit lamp and you need a thumb because you're able to check MGD. You're able to check for corneal staining. The questionnaire will lead you down the path of what their symptomology is. And you need the slit lamp to look at their eyes. With allergy testing, you can add a few questions to your questionnaires that your patients fill out at the beginning to kind of direct, does this patient have any allergic symptoms that may lead me down the pathway of doing some type of allergic point of care test? Some different questions you could ask. You could say, does allergy run in your family? Add that. It's an easy, simple question. Do your eyes itch? We'll talk about some symptomology things a little bit, something very easy to add. And then, do you tear up when you use certain cosmetics or perfumes? Those would be 3 different questions that you could consider adding to a questionnaire that can lead you down a path of maybe this particular patient is struggling with things besides dry eye. They have some allergic pieces as well. So keep that in mind as we kind of get into this. Yes, we're going to focus on allergy, but there's other pieces that kind of go along with this. Dry eye, blepharitis, all these things can create issues for our patients. So when we look at the stats around this, ocular allergies, 55% of patients, 55% of people in the United States will test positive to at least one allergen. And a lot of times they're testing positive to multiple allergens. Huge number of Americans suffering with allergic disease. And then the 6th leading cause of chronic illness in the United States. And that number really blows me away when you think about chronic illness in the United States. Because what are our main chronic illnesses in the United States? Heart disease, cancer, diabetes, asthma, which asthma goes along with ocular allergies. And I think at times, and I'm at fault for this a lot, that I underestimate the chronic nature and the quality of life issues that allergy causes to our patients. The 6th leading cause of chronic illness in the United States. So keep that in mind as we kind of go through this. And I say that mainly because when I think of cancer, diabetes, heart disease, those are real things. Those are things that are life-threatening. They definitely create quality of life issues as well. But this being the 6th leading chronic illness in the United States definitely is something that we need to pay attention to and we should manage. And we see these types of patients in our practices all the time. More review here, the common causes of different types of allergies. I've listed them all here. I think a few of them are not going to surprise you. Tree pollen, grass pollen, weed pollen. I think that's stuff we understand and know. When I saw cockroaches, I was surprised. I didn't think cockroaches would really be one on the list. But as you go through and do your research on this, cockroaches is something that can create a lot of ocular allergies. A big one here, cosmetics. You look at the stats around cosmetics, 42 ingredients in certain cosmetics, a lot of these things being chemical or metallic components, which create real issues with the ocular surface, not only from an allergy standpoint, but an MGD standpoint as well. So I think it's important to ask your patients, talk to your patients about the cosmetics they're using and if they're bothering them at all. There's some specific eye cosmetic companies that have been working on safe and effective cosmetics for the eye. And many of you probably have heard of these different companies that are out there. One started by an ophthalmologist, another one that's been around a bit longer and really already worldwide. And so not naming them, but they're out there and they're focused on providing cosmetics that are safe for the ocular surface that will decrease ocular allergies from those as well. I think one thing to point out when we talk about all the different treatment options tonight, when you look at the common causes here, the number one way to really treat ocular allergies is avoidance. There's different studies you look at that would say, boy, 90% of ocular allergies can be treated by just avoiding the allergen. And that's why when you look at these common causes, if we can pinpoint or find out what our patients are allergic to, if we avoid the allergen, we can make their lives better. If we educate them how to avoid it, preservative-free artificial tears, wiping out the surface of the eye. If we can use that along with avoidance, a lot of our patients can be treated for the different types of ocular allergies that are out there. When we think about signs and symptoms, I think the biggest one for me is itch. And I think you all would agree with that itching is the hallmark symptom that a patient will complain about to us. Now, all the other things you see here can overlap with blepharitis, can overlap with dry eye syndrome, ocular surface disease. We think about blepharitis, for example, the scaling, Demodex blepharitis. We need to have our patients look down, they get the collarettes. That can create itching as well. So that can overlap at times. But a lot of these hyperemia redness happens in all three of those that we talked about earlier, the burning, the watery eyes, swollen eyelids at times. But the itching to me is the hallmark. And so if a patient is complaining about itching, and that's why we have it on a questionnaire in our practice, then that to me is indicating that there's probably some type of ocular allergy. That's a piece of it. So I want to pause here for a minute and talk about the photos that you see here, mainly the image there with the patient that's eye rubbing. There is this connection too between ocular allergies and keratoconus. There was a study published in Cornea in 2019 looking at the relationship between patients that were patients that had allergic conjunctivitis and developed keratoconus. This was a Korean population. It was a 10-year study, and they looked at the percentage of patients that ended up with keratoconus and had allergic conjunctivitis. So if you had allergic conjunctivitis, there was a 37% higher chance that you would end up with keratoconus or diagnosed with keratoconus versus patients that did not have allergic conjunctivitis. Why is that the case? Because they're rubbing their eyes, and we know that rubbing of the eyes is connected to keratoconus. They go hand in hand in a lot of our patients. So I think it's very, very important that when you diagnose a patient with allergic conjunctivitis or any type of ocular allergy, that you also talk to them about eye rubbing. It's very important that our patients are not rubbing their eyes, aggressively rubbing their eyes. Feels great. When you have an itch, what do? You rub, and it feels awesome. But it's so important to talk to our patients about not rubbing their eyes because they're damaging their corneas. It's leading to situations like keratoconus, which we could treat the ocular allergy, but once they have keratoconus and that's progressive in nature, that's a lot harder to manage and to treat. So the allergic cascade, we'll kind of touch on this, and there's a variety of different ways that this is described or talked about, but there's really no debate that it's really three phases. You have that sensitization state, you have the early phase, and then you have the late phase of the allergic cascade. And so the first phase, this sensitization phase, is really when the person is being exposed to the allergen. And this is when a situation where the patient isn't coming into your clinic. You don't see them. These are situations, these patients aren't coming in because why? They're not symptomatic. They really don't know they have a problem at this point in time. They're being sensitized to the allergen. What's happening is you have this IgE-mediated antibody joining with the associated mast cells. This really begins the activation of the allergic cascade. But again, they're not symptomatic, and so they're not coming in to our practice. As they get exposed to the allergen more and more, additional exposure, whatever that may be, you saw all the different causes earlier in the slide deck, then the degranulation process starts of those mast cells, which creates the histamine release, the prostaglandin release, kind of that inflammatory cascade, which is going to lead to the next phase, which is the early phase. And this is when the patient becomes symptomatic. This is when they start having issues with itch, with some redness, with maybe some tearing, some swelling, those types of things. And so this may be where the patient seeks out our care, where they come into our office with this particular situation. And the more the exposure, the greater the exposure to that antigen, there's going to be more of that IgE-mediated breakdown with the mast cells, which is going to stimulate a greater allergic response, which is then going to lead into the late phase. And this is really where, again, patients may show up in our clinic because now they're having real problems. This is where you could start getting some systemic problems. So it's the ocular allergies. You may get patients that come in with drainage through their nose. There's drainage down to the lacrimal duct system. This is where there's a real inflammatory process occurring, and it's persistent. And it's going on and on and on, and patients aren't getting better until they're treated when they're in this particular phase. And so that was a brief overview of kind of the allergic cascade. Again, I know there was an in-depth discussion on this in earlier lectures, but I wanted to review it as we kind of get into the different treatment options. And I'll allude to these when we start talking about the different treatments, like topical corticosteroids. Where do they fit? When we talk about, the mast cell stabilizers or the dual activity agents, where do those fit in this particular cascade? So more of a review to kind of discuss that. So when we think about the different types of allergies out there, 90% of what we deal with is seasonal and perennial. And the name tells you what it is. Seasonal, they're going to come and go. Seasonal allergic conjunctivitis in South Dakota, spring and fall are terrible. We don't see a lot of it in the winter. But you also have the perennial, which is year round, and you can see the different typical causes of that. I'm going to talk about VKC briefly, and I am going to talk about atopic keratoconjunctivitis briefly as well, mainly because with VKC, there's a new medication that just came out, and we're going to talk about some treatment options for that. And then AKC, I think worth mentioning as well. The last one there being GPC, really not an ocular allergy, probably not IgE mediated, more inflammatory mechanical irritation associated with contact lenses. I threw it on there because we do see in our clinical practices, especially contact lens practices, GPC, but this not the same as the top four that we talked about here, being seasonal and perennial, being IgE mediated. VKC also have an inflammatory component, being T cells, and then atopic also being inflammatory as well. So let's talk about Vernal first and identifying this. So number one, this usually affects young patients, 8 to 12 years old, typically males. It's both IgE mediated as well as T cell mediated. So you have an inflammatory component and an allergic component as well. It is typically seasonal. It is relatively rare, so it's not something you're going to see very often. And it is reoccurring. So seasonal, but reoccurring. And there's really 3 different things that you're going to run into when you see this and how you want to diagnose. The first is the image that you're looking at right there. Those are these gelatinous kind of raised bumps that are at the limbus on these particular patients. These are Horner-Trantis dots. So they look white, gelatinous, and raised. The next thing you're going to see are these is essentially GPC, or these upper, very common with VKC as well. Now, you don't have to have all the 3 things I'm going to talk about here. You could just have one of the 3, and it could still be VKC. The toughest thing you can get with VKC is what we call a shield ulcer. It's called a shield ulcer because it just doesn't respond to treatment. You may see this. It may start off small. You're treating it like you would an ulcer. It doesn't look infectious. It may look infectious. You're putting them on an antibiotic. You're maybe holding on a steroid, but the term it gets is a shield ulcer because it is very difficult to treat and it's very resistant to therapy. So those 3 things are the 3 things you think about with VKC, as well as the patient's particular age and gender as well. So how do we treat this? Well, there's a new medication that has come out recently, Cyclosporine ophthalmic emulsion. We're used to cyclosporins. We've heard of cyclosporine. It's a 0.1% formulation. This is a preservative-free drop. It's dosed 4 times a day, 1 drop. So 1 drop 4 times a day, up to 4 months. Typically, that's the dosage for it. You want to go 4 months with this. You were looking at some clinical trial data here for this particular medication. On your left side there, we're looking at an ocular itching score. In that first study, there was a 57% reduction of itching from baseline out to 4 months. That's how long the study went. In the green, what you're looking at is a 4 times a day dosing. In the yellow is 2 times a day dosing. And in the gray there is your control group. That's the ocular itching group. The second study, corneal staining on your right there, looked at the decrease in corneal staining. And this was central, inferior nasal, inferior temporal, superior nasal. And there was a 53% reduction from baseline in corneal staining. The way that these studies are done, a CFS score, each section of the cornea, the 5 I talked about, are labeled on a scale of 0 to 5. So a total score would be 25 because the superior temporal is labeled 0 to 5 from a staining. Central is labeled 0 to 5, inferior nasal 0 to 5. So you can have a total of 25. You can see here at baseline, these patients had corneal staining, but it was a fairly low number. When I see that, and you see it cut in half, that's pretty impressive because you didn't start with a number of 10 or 15 of the corneal staining, which to me would be a lot easier to lower. Started with a low number with this particular medication, 4 times a day in the orange group, 2 times a day for 4 months in the green group, and then the control group in the gray. And you can see a 53% or so reduction in corneal staining with this particular medication. And so you diagnose VKC, this would be something I would consider. Again, 4 times a day, preservative free, 1 drop, 4 times a day for 4 months. This is just an image of 4-month treatment for a patient. You can see the top, those kind of giant papillae that we talked about with VKC. You can see after 4 months of treatment at 4 times a day, what the image looks like inferior. That patient obviously feeling a lot better after treatment with this particular medication. When we talk about atopic keratoconjunctivitis or AKC, this is a chronic perennial bilateral conjunctivitis. So this affects patients year-round and typically is associated with atopic dermatitis. You can see the percentage there at 95%, or asthma. And 1 to 8% of the adult population is what that's affected by. So it's fairly rare. But for me, recently, I feel like it's about 50%. I just had recently, 2 or 3 patients come in with atopic keratoconjunctivitis. And interestingly enough, both being associated with atopic dermatitis. And so you have to manage the systemic component of this as well. You don't want to just manage the atopic ocular piece. You want to manage the atopic dermatitis as well. How do you manage that? You work with a dermatologist to get it managed in that regard. The signs and symptoms you can see here: itching, eczema, symblepharon, pannus as well. These patients typically will do very well with topical corticosteroid. The patient I had the other day, unfortunately, not only had atopic keratoconjunctivitis, but because of having blepharitis, he ended up with a corneal ulcer. And so you're managing that as well. That's why it's important to jump on top of these patients, treat the inflammation, work with dermatology to make sure that these patients are taken care of. It's a chronic inflammatory disease that typically will affect patients in their late teenage years out to their 5th decade. And we really still don't understand the pathogenesis of this particular condition. What about allergy testing? I alluded to this earlier when I talked about the overlap of dry eye allergy as well as blepharitis, and really the symptomology of itching being kind of the telltale of an allergic issue. And so allergy testing for us in our practice doesn't happen for every patient, but it happens for patients that come in often with allergy issues or non-responsive patients to dry eye therapy that we're kind of questioning. Maybe there's an allergic component here that we're just not attacking and taking care of. And you can see the variety of different things listed here where you may want to consider allergy testing for your patients. What are the different allergy tests? So outside of our clinic, and I'm going to talk about a point of care test here in a little bit that is inside our clinic, these would be outside of the clinic types of testing. The blood test. This is being done. It's a new gold standard that was established in 2010. It's not quite as sensitive as skin testing. It's a little more costly. But really the beauty of the blood test is patients don't have to stop their systemic therapy that they're taking. If they're taking an antihistamine, an oral antihistamine, or they're taking something for eczema or whatever it may be, they don't need to stop it because there's no issue, because we're just drawing blood and looking for really IgE levels in the blood. So that's really the advantage of the blood test. Now there's a needle involved. You have to draw blood. So that's probably the downside. Kids aren't going to love this as much as they'll maybe love the skin prick test, but I don't think anyone loves skin prick test either. If you've been through it, I have. As a kid, I had fairly significant allergies, went through the skin prick test. It's not a lot of fun either, but the blood test, simple, effective, and you don't have to make patients get off their systemic medications when they're doing it. The cutaneous skin prick test, they have to stop these things. They have to stop their antihistamine. They have to, if they have bad dermatitis or eczema that's not being treated, the results may not come through. You may not get a positive result with this. And really, again, a tougher test to do with children or younger patients. And so this is really the advantages or the differences between the two. Again, primary care providers typically are going to order the blood test or skin prick test. We'll get into a point of care test here in a second that we could order. Allergy testing, we talked about that. The needle stick, we talked about that. You don't have to worry about a severe allergic reaction. I think that's a very important point with the blood test, where essentially with the skin prick test, these patients are being exposed to an allergen. And so they could have an allergic reaction that's fairly significant to that skin prick test. And so you need to be aware of that. And then a couple other things listed well that I'm repeating myself, so I'll kind of move on from that. Now, what can we do in our practices? What are some available options? So there's a scratch test available, and there's a couple of these out there, 2 different companies that have these. This is a billable CPT code that you will get reimbursed for if you're doing it and you have medical reason to do it. One of the scratch tests tests 60 different allergens, and it's specific for different parts of the country. And I'll come back to this in a second, but I'm going to kind of show you this kind of breakdown of this regional specific antigen panel. So it's looking at 60 different allergens specific to the region that you live in. So they'll formulate this for you wherever you particularly live so that you can test your patients with this. One thing to take home about this is if the patient does not react to the control, which is histamine, they should react to histamine, should have an allergic reaction if histamine is being scratched on your skin, then I always think and want to remember that there could be an underlying autoimmune disorder present. And so if you start to do this test, keep that in mind with the control. It's a very quick test, really only takes about 3 minutes. You have results in 10 to 15 minutes. And the one thing about this test is you will want your patients to kind of delay their ocular or oral, mainly their oral anti-allergy medications if they're taking it, so you don't throw off the test if you're going to go ahead and do this in your practices. There's another company that also has a skin or scratch test. This particular one tests more allergens. This tests about 78 allergens. And what's interesting about this other company is they have subcutaneous or sublingual therapy that can be utilized to manage your patients as well. The beauty of having this is you can pinpoint what type of allergy they have. What are they allergic to? What allergen are they allergic to? And it goes back to that avoidance piece. It goes back to how do you avoid patients from getting ocular allergies? Well, if you know exactly what they're allergic to, you can educate on avoidance. You still are going to utilize some of the treatment options we're going to talk about here in a little bit, but the avoidance piece is so important. And this allows you to do that in your practices. Again, reimbursable with the CPT code, the sublingual or the subcutaneous treatments with the other allergy test, patients do pay out of pocket for that. All right, so let's get into the goals for treatment to kind of get into the second half of the lecture. And really, in my mind, it's very simple. We're trying to stop the inflammatory cascade. We're going to make our patients feel better if we do that. How? We're going to stop the itching. We're going to decrease inflammation. They're going to feel better. And we have great medications to do that with. And then we're going to provide the relief for our patients. And that relief is conjunctival swelling. That relief is mainly the itching when we think about the inflammatory cascade that is involved with itching. So this is really a stepwise treatment strategy that I think about with allergic conjunctivitis or allergies in general, ocular allergies. You have the primary, you have the secondary, and then you have those tertiary treatment options. The primary I've mentioned, a lot of times it just comes down to avoidance. If you can figure out what they're allergic to, you can have the patient avoid it. Cold compresses, preservative-free tears. A lot of times I'll have patients stick their preservative-free tears in the fridge because it feels much better. And then the combination of topical antihistamine mast cell stabilizers, that dual activity, can be utilized in that early phase as well. We're going to talk about some oral anti-allergics in a little bit of where those should come into play as well. When you get into more advanced allergies, more advanced ocular allergies, that's where you're going to start to use the combination antihistamine mast cell stabilizers. To me, a single mast cell stabilizer is fine. You're going to see the downside to that in a little bit when I get into the treatment. To me, it's really nice to have these combination ones. That's really what you want to attack with. Why? Because it's doing the same thing a single agent mast cell stabilizer is going to do, but you get the added benefit of the antihistamine, which is going to help with the itching. And we'll talk about that here in a little bit. And then topical corticosteroids can be considered in the secondary agent as well. And then the final or tertiary stepwise approach would be the topical corticosteroids. Short course, we have a lot of good, what we call soft steroids out there, and I'll touch on that here in a little bit. The immunomodulating agents, we just talked about one of those a second ago, the cyclosporine 0.1%. And then possibly if your state is in that kind of realm, the oral steroids can be utilized as well. I'll admit it's rare that I have to prescribe an oral steroid for ocular allergies. I usually can get by with topical corticosteroids and the combination antihistamine and mast cell stabilizers to manage these particular patients. Very, very busy slide here. And I don't want you to memorize it. This will be in your handout as well, but it kind of breaks down the areas of where the different medications that we're going to get into are working. You have the mast cells. We talked about how this breaks down the IgE mediated, reaction with the mast cells. The mast cells degranulate, and then you get the symptomology. Well, the mast cell stabilizers work really at the top. The problem with the mast cell stabilizer is remember the patient typically when they come into your practice has already had degranulation of the mast cells. And so they're symptomatic. They're either itching, they have chemosis, they're red, they're inflamed. And so if you can get out in front of it, yes, the mast cell stabilizer is great. But the problem is most of the time the patient's in your office in the early or late phase. And that's really why we need to move down this cascade and think about topical corticosteroids or the combination antihistamine mast cell stabilizers. Why? Because the antihistamines are going to decrease symptomology. They're going to decrease itch. And with topical corticosteroids, they're really our strongest option. They're going to knock down that inflammatory cascade, and they do it early in the process, and they do it on both sides of this inflammatory cascade, as you can see here as well. And then we also have NSAIDs that we'll touch on also that can work in this cascade as well, but they don't really help with the itching component or the symptomology component, as you can see on the left side of this particular breakdown. So let's talk about antihistamines first. What do? They bind to H1 histamine receptors. What does histamine do? It really causes itching. Histamine causes itching. And so antihistamines are blocking that. So it's controlling itching. They work quickly. That's really the beauty of these. They work fast in 3 to 15 minutes. And for me, antihistamines, I'm using them more if I'm going to use them. I'm talking to the primary care provider or an allergist to really get them on board with an oral antihistamine, because a lot of times when I'm managing patients with allergies, I'm going to use the combination antihistamine along with the mast cell stabilizer, because I'm able to prevent more mast cells from degranulizing, and I have the antihistamine to control the itch. But I like the oral agents, as we'll talk about here in a little bit, to manage some of the issues that you run into when you're getting rhinitis or nose issues or other things with asthma, a variety of those types of things. And so for me, the topical antihistamines, I don't use them a ton. I'm typically utilizing the combination therapies more often. This is just kind of a breakdown of the different topical antihistamines. Now, keep in mind, some of these do have a little effect on mast cells as well. But if you look at the classification of these, they're classified as topical antihistamines. These are a variety of them, some BID, some QD, and some of these RX, some of these OTC as well. When we think about the dual activity agents, these are really my workhorse ones. I love these because, they work, I don't want to say better than the antihistamines, but they're covering a more broad spectrum of things that we need them to do. They're not allowing the mast cells to degranulate. They're also helping with the itch component. So you have the prophylactic benefit. And then on top of that, you have the immediate relief that you get with the antihistamines. You can see where these work in that kind of inflammatory cascade or allergic cascade. They're blocking the mast cells. They're blocking histamine, heparin, all of those different agents. So the itch is controlled with these. And these are all over the counter at this point in time, which is really nice to have. You can see the different dosages here, 2 of those being QD, the other one being BID. Again, great options for your patient, OTC as well. I still like to recommend it to my patients. I like to tell them which one I want them on so that they just don't grab one off the shelf. But these things are OTC. And for me, my workhorse ones when I'm dealing with ocular allergies, especially my seasonal ones that are coming and going, South Dakota spring and fall. NSAIDs, got to talk about them. Don't play a huge role for me when I'm talking about ocular allergies. They play a role in other different situations in my practice. These aren't as powerful as steroids, as all you know. They don't really help with itching. And so to me, if the patient's symptomatic, they have itching, I'm going to lean more towards that combination dual agent that we talked about a second ago, or really jump into what I really like to use, which is our topical corticosteroids. This is your topical NSAID, the ketorolac, comes in QID or BID dosing. But this is something I think is very underutilized when we think about ocular allergies, which is the topical corticosteroids. You can see where they work at. They work at the top of this inflammatory cascade or towards the top of the inflammatory cascade. You could see they're underutilized in eye care. Only about 10% of corticosteroids are used as first-line therapy when we're talking about ocular allergies. And I would say I reach for it more. I reach for it more than 10% of the time because it works so well to get patients off being symptomatic. It doesn't mean I don't use the dual agent combination agents that we talked about earlier. But if I have a patient that presents to my practice that is even in the early phase of the allergic cascade, or especially the late phase of the cascade, I will strongly consider putting them on a topical corticosteroid. This is going to be a short-term therapy. I'm not going to use this for an extended period of time. I'm comfortable using these out to a month, But after a month, I'm going to get them off of it. And that's when I'm going to get them on one of those dual types of agents to kind of control the situation. And then if I need to pulse dose this topical corticosteroid at different times, I'll do that. And that brings up the patient education piece. So important to educate our patients because they don't necessarily understand how ocular allergies work. They don't necessarily understand that once they get this medication and they're healed, they're doing better, that it may come back in the fall. Let's say, for example, they have it in the spring. They think, well, he cured me and I'm better and it shouldn't come back. So the education is very, very important. And so pulse dose, the topical corticosteroid, I think we should be utilizing it more in clinical practice because they're very effective at what they do. And we have a whole slew of them, as you can see here, the lodiprednol types. We have a fluorometholone, the prednisolone acetate. We're all very familiar with these, and you can see the dosages of these as well. And you can play with the dosages a little bit. If I have a very late phase allergic situation, I'll do QID for 2 weeks and then cut it down BID for 2 weeks and keep them on it for that full month. If it's a patient that's very early on and there's not a ton of chemosis, not a ton of hyperemia, they're not having a ton of itching, I'll go ahead and just start at BID and maybe only keep them on it for 2 weeks and recheck them, and that will do the job. So you base it really on the level of the allergic conjunctivitis, how inflamed the patient is, how much of symptoms they have, how big their complaints are, but we have good agents there as well. What about beyond, the oral, what about beyond the topical or the ocular allergies? We do need to take the opportunity to work alongside colleagues in our community, whether that be allergists, whether that be primary care providers that are managing some of the other things that we run into. Because if you have a patient that comes in that late phase, a lot of times they're going to be complaining also of postnasal drip. And I'll ask them about these things. They're going to be having nose or sinus issues as well. Asthma obviously is a piece of this as well. And a lot of times just the topical agents that we talked about aren't going to be enough to control the situation. Yes, we'll treat the ocular allergy component, but sometimes these other histamine agents, you can see 3 of them there listed. The first 3 are going to be needed to really control this patient's systemic piece, the part that's going on with the nose, the lacrimal duct system, the postnasal drip, the asthma. With asthma, typically that's going to be the singular that you see there, again, provided by the allergist or the primary care provider. And then the Flonase piece as well, which is a synthetic steroid, a glucocorticoid, really dosed each nostril, 2 sprays once a day. And so again, working alongside an allergist in your community, or working alongside your primary care provider gives you the opportunity to remind them that number one, you're part of the healthcare community, but number 2, your expertise in the ocular allergy world. And this really affects patients' quality of life to a high level. So don't forget about the systemic components that are contributing to this as well. So in wrapping up, I'm going to kind of now get outside the box of our traditional therapies, and we're going to get into some of the more, futuristic things that are coming. 2 of these medications or 2 of these options I'm going to talk about are not available. The next option I'm going to talk about is available and on the market, and some of you may have utilized it already. This is a dexamethasone ophthalmic insert. So it's a steroid, 0.4 milligrams, and this is an intracanalicular insert. Essentially, it's a plug. And the way that it works is it releases dexamethasone in a controlled fashion for up to 30 days. And this has been used in cataract surgery, which a lot of you probably are familiar with. It's been around longer for that. It's approved for pain and inflammation after cataract surgery. But for our discussion tonight, it's actually approved for allergic conjunctivitis now. So it is FDA approved to be used for allergic conjunctivitis. You can see it's for the treatment of ocular itching associated with that particular condition. If any of you have inserted this, it's a beautiful technology. There is a little bit of a learning curve with it. And so if you start to utilize it, what I would definitely recommend is don't get discouraged doing your first, second, third one. And I would pick and set yourself up success by picking punctums that are not tiny, that are not small. Pick punctums that are larger, wider open, because when this hits a little bit of fluid, a little bit of liquid, it will actually expand. And it does that. And that's a good thing because it won't fall out once you get it placed. But if you do this on a small punctum right away, right off the bat, you're not going to love it because you're going to have trouble getting it in the first time. You need to dilate these patients. And so you're going to see a video of it here in a second. So use a punctal dilator. You go ahead and dilate the punctum. You'll then insert this and you use a forceps, just like shown on the image there. And as soon as it gets into the punctum, it's going to go ahead and start to dilate. it will release this dexamethasone. And you can imagine you're getting a nice dual mechanism with this. Really, you're getting the dexamethasone with the steroid, but you're also getting punctal occlusion, which can help with if they're having any ocular surface disease issues as well. It is preservative free and it does dissolve on its own. And so it will go away after about that 30-day period. It is conjugated or filled essentially with sodium fluorescein. And so if you take a cobalt blue light, use a Ratten filter, you can visualize it and it just lights up very bright. It's that neon color and you can visualize if it's there or not there. And you'll see that it eventually will dissolve with time. When we look at the clinical trial studies on this, a phase 3 study, you can see phase 1 study, phase 2 study, phase 3 study. This is at day 8 ocular itching score. It's a score of 0 to 4. Really what they do to these patients is it's a conjunctival allergen challenge test. I would never sign up for something like this, to be honest with you. It sounds miserable, but I'm glad there are patients that are willing to do it because that's how we get data and we get studies. Essentially, they're exposed to an allergen in their eye, and of course, they start to itch. That allergen is going to be histamine most of the time, and so they're itchy, they're irritated, and then of course, one of these is placed. And at day 8, they look at these patients. So the way it works is they expose them to them. On day 8, the plug's already been placed, and you can see at 3 minutes, 5 minutes, and 7 minutes after they've been exposed to the allergen, what happens to the ocular itching score. And you can see it outperforms the vehicle pretty significantly and pretty statistically significantly across both study 1, study 2, and study 3. So let me show you a quick video of this here in a second. And then I think another common question I get is, well, will it raise IOP? Because we hear dexamethasone, we say, boy, dexamethasone, steroid response, it's going to make the pressure go up. Makes me nervous that it's inside and I can't really remove it. You can flush it. So you can use a cannula and you can flush it if you needed to, but the safety profile, very, very good. You can see increased IOP in these patients, extremely low, only 5 patients. And really most of them didn't need any management. The few that did, topical therapy did the job to lower the intraocular pressure. And you can see here before the stent was placed, before the intracanalicular insert was placed and after. And you can see at day 30, really no difference from the vehicle, which is in the gray, versus the intracanalicular insert, which is in the blue. And so I don't really worry about IOP spikes in these particular patients. I've never ran into it on the times that I've utilized this. Not really a concern at all that you'll see. So this can be done at the slit lamp. In this particular situation, it's being done with the patient in a supine position. So they're being laid down. You can see the punctal dilator already there being used. So it's dilating the puncta, the forceps with that insert in hand, they slide it in, it goes all the way down and immediately that's going to begin to expand. Again, that's being done in the OR. I'll tell you in my practice, I'm doing this behind the slit lamp. And the way that we do this, we don't have the patient lie down. You can. So a couple different scenarios here. You could have the patient lie down and you could do it. I'm just going to skip ahead here. I'm going to back up one so that video is not just going over and over again. You could do it 2 different ways. You could have the patient lie down in the exam chair and you could use some loops so that you can identify what you're looking at. I prefer to do it behind the slit lamp. You always want to punctal dilate. You always want to make sure you dry with some type of wick sponge around the punctum, because again, as soon as that intracanalicular insert gets wet, it's going to start to expand. And if it starts to expand on you before you get it where it's supposed to go, it becomes much more difficult to get it to the area that it's supposed to go. And so you want to punctal dilate. As soon as you remove that punctal dilate, dry a little bit. I have my scribe or a nurse or a technician standing right there with it already loaded, ready to go. They hand it to me. I put it in, you're done. And I'll tell you, it's going to take you about 10 times to get comfortable with it. But once you get comfortable with it, it's a great option to think about for your patients with allergic conjunctivitis. Why? Because of compliance. We think about compliance issues with our patients. We know this in the glaucoma world. We know this in the cataract world. We know it even in the allergic conjunctivitis world. Our patients, even though we recommend certain topical therapies, they don't always do what they're told to do. They forget doses. The beauty of something like this is it's there. They don't have a choice. And it's a steroid, which we know will decrease that inflammatory cascade and can help our patients with allergic conjunctivitis or allergies in general. So this is a medication that's not available, but something I'm really excited about. These reactive aldehyde species, or RASP. RASP, actually, I'm going to show you kind of where this is in the inflammatory cascade, has been shown to be associated with a bunch of different ocular diseases: dry eye, autoimmune disorders, allergic conjunctivitis, which we're focusing on tonight. And I mentioned dry eye disease as well. The interesting thing about this is there's a particular company working on RASP inhibition. And if they can inhibit RASP, which I'll show you clinical trial data here in a second, then they're going to be able to decrease not only allergic conjunctivitis symptoms, but also probably help with autoimmune conditions, also help with dry eye disease as well. And so this not yet FDA approved, still undergoing clinical trials, is actually an exciting technology that you're going to hear more and more about. It is a drop, but this is kind of how it sets up when we look at the inflammatory cascade. It actually is believed to work earlier, the RASP inhibitor, which is called Reproxalap, to work earlier than where corticosteroids work or where our immunomodulators work. Remember, immunomodulators decrease T cell activation. We know that our corticosteroids decrease cytokines. You can see where RASP kind of is in this inflammatory cascade. And so Reproxalap may bind and block RASP earlier in that inflammatory cascade, which then would obviously decrease inflammation, pain, redness, swelling, and then that kind of ciliary flush or that skin flush or heat around the eyes. So to share kind of a phase 3 clinical trial that is ongoing, you can see here Reproxalap, which is in the purple, versus the vehicle, which is in the gray. These patients were actually placed in an allergen chamber, so they're exposed to an allergen. We have a primary endpoint and a secondary endpoint here as well. One looking at ocular itching, the other looking at ocular redness. They received one dose and then they received a second dose. You can see a very statistically significant decline versus vehicle with the Reproxalap group. Remember, with ocular itching, it's on a scale of 0 to 4. Redness also on a scale of 0 to 4. And you can see a significant decrease down to about 1 in the ocular itching group and below 1.4 in the mean ocular redness group. So definitely a medication to keep your eyes out for. I think this could have and make a lot of noise, not only in the allergic conjunctivitis group, but also in the dry eye space as well. The final piece wrapping up here, an antihistamine-releasing contact lens, which has been FDA approved, not quite available for us to utilize at this point in time. Limited in the fact that it can be used, but only used with patients up to 1 diopters of astigmatism. So if it's above 1 diopter of astigmatism, you won't be able to get the visual benefits from it, but it will have power in it. It will be able to correct visual acuity. It will have the ability to help patients in that regard. It is daily disposable. You can see what it's infused with. And it is going to be indicated for the prevention of ocular itching due to allergic conjunctivitis. And this is exciting to me. I have a passion for drug delivery. I have a passion for drug delivery in the glaucoma world. Anything in glaucoma drug delivery or drug delivery in general excites me. And to have something that's going to be available in a contact lens, something that optometry is heavily involved with. We own contact lenses. We're now going to have a medication infused contact lens that we can use to treat a condition, to help with a condition that is very, very common. Talked about it earlier. 6th leading cause of chronic illness in the United States is exciting. And there is data around this as well. You can see 15 minutes of wear time, 12 hours of wear time, what's happening to that mean itch score in both of these situations early on and late on in wear. Very effective against the control lenses, which obviously are not drug infused. You can see a big decrease in that itch score, again, on a scale of 0 to 4. And exciting to see it that low as well. I mean, it's probably going to be very effective in managing and helping our patients. So really, in conclusion and wrapping up, I know we're kind of right at that time. Remember, I know we talked a lot about allergic conjunctivitis, but there's a huge overlap between dry, blepharitis, allergic conjunctivitis. You're probably going to be treating all 3 of these at the same time quite often. The key to treatment is we need to stop that inflammatory cascade. We talked about the different agents tonight. We talked about some future agents tonight. Stopping the inflammatory cascade is really the key. And we need to continue to embrace new technology when it comes to the market. When this contact lens is available to us, embrace it, utilize it, get used to it. Think about this intracanalicular insert in your practice. Where does it fit? Take the time maybe to do 8 to 10 patients and get comfortable with it. And I think you'll find that it can be helpful for your patients as well. If you have any questions, please email me. I know we have a little time for questions. So I know Ariel's going to come back and kind of throw a few at me, and I'll do my best to answer those. But also feel free to email them if you have any questions as well. And again, thanks so much for being here tonight.
Awesome. Thank you so much, Justin. That was great.